Hello, everyone. I want to welcome everyone to another round of HIV and Global Health Rounds. Today, I have the distinct pleasure of introducing my colleague and friend, Dr. Jill Blumenthal. So we're going to do things a tiny bit differently today, and I'm going to ask Dr. Blumenthal a few questions so she can introduce herself. Dr. Blumenthal, where are you from?
What, did you say, where am I from?
Yeah.
Well, born in Baltimore, Maryland, but spent most of my life in New York. And that is where I lived. I was in Manhattan for about 10 years before moving out to San Diego for my fellowship in 2011. And I've been here now for 10 years. Okay,
great. Well, you kind of answered a lot of the same questions.
I know. That was
more about your education.
That was the trick.
And then what brought you to San Diego as well?
Okay. Yeah, well, that was the fellowship.
Yeah, all right, awesome. And then tell us an interesting fact about you.
Okay, well, I mean, I don't want to be there's something at the end that I'll save, which would probably be my most interesting fact currently. And I have something for that at the end. So my other interesting fact is that I didn't grow up with any animals. And as a lot of people know who know me, I've now had a dog for over a year who I'm moderately obsessed with. But we also have a bearded dragon. And I feel like we give Murphy a lot of short shrift, and Murphy is great. And those are, so I went from a non-pet owner, except for fish, to a dog and a bearded dragon. And it's been a lot of fun. All right, Darcy. Here, wait. Here's her paw that I keep with me at all times.
Well, I would say it's hard not to be obsessed with at least your dog, Tallulah. Great. So, yeah. All right. Well, would you like to get started?
Sure. Thanks, Marvin. And I will try to go back to a more serious person now. But I really, I want this to be, as much of an open exchange as possible. I realized with my own fault, I did not ask questions, which would have engaged people a little bit more. But please feel free to unmute yourself, raise your hand. I can see the chat, and Dan Lee's going to be keeping an eye on it as well. But would love to hear from people as we go through. So today I'm going to be talking about long-acting injectable antivirals, a promising but potentially polarizing strategy for HIV prevention. These are my disclosures. So what I'm going to be talking about today, first are two very exciting studies. One, although it's been presented at multiple conferences, hot off the press in its as a manuscript in the New England Journal of Medicine, HPTN 083, and then I'm going to talk about its I guess its sister study, or its companion study 084. And then I want to spend a lot of time talking, or the rest of the time talking about Lena Capovir, which is a newer agent on the scene for long-acting, that is a long-acting injectable medication. And I'm going to talk about it both in the context of treatment, but focus on it more in terms of prevention. So this was very big news that, and I know a few people have read the article, the HIV Prevention Trials Network published their results on August 12th. PrEP containing long-acting cabotegravir is safe and highly effective for cisgender men and transgender women who have sex with men. I just wanted to go through the study. I think it's been discussed before, but now we have all of the data, or at least most of the data in one nice spot. And if you haven't read the article, I highly encourage. So for those who don't know, or just a reminder, 083 was a phase 2B randomized, double-blind, double dummy study at 43 sites globally It enrolled MSM and transgender women over 18. And the risk was somewhat generous, although making sure that there was some risk involved. For those who attended Dr. Alu's talk, what is risk? Does it matter? Someone just wants it. Well, in studies like this, we do have to make sure that we are enrolling individuals with some risk so that we can see if there is either non-inferiority or anything else. So any condomless receptive anal intercourse, more than 5 partners, stimulant drug use, and incident rectal or urethral STI or incident syphilis in the past 6 months, or a sex pro score of less than 16, which is the app that Dr. Liu talked about last week. No hepatitis B or C, and then no contraindication to gluteal injection seizures, gluteal tattoos, and skin conditions. Plan to enroll 5,000 people. Now, this is where, I think this is really exciting about this study, and you'll hear me talk about it when I talk about Lena Capovir for prevention. The goal was to enroll more than 50% under age 30, more than 10% transgender women, and more than 50% of US enrollment for Black individuals. And this is to reflect where we know that that HIV incidence is still increasing, and to really make sure that these groups are represented. And the primary efficacy endpoint were incidence HIV infections during the blinded comparison, and then the primary safety endpoint was grade 2 or higher clinical and laboratory adverse events. Sorry, and I'm just trying to see this a little bit better. Okay, so here's the study design. It was a 1-to-1 randomization, and basically there was an oral lead-in for 5 weeks, and you were either randomized to cabotegravir or the placebo for cab, and then for 3 years, you got every 2 months. For every 2 months, you got an injection either of cabotegravir with placebo, TDF-FTC, which is Truvada, or the cabotegravir placebo plus oral TDF-FTC. So the comparators really were basically injectable cabotegravir versus Truvada, and then in step 3, there was a washout period where everyone continued on TDF-FTC so that they could look at cabotegravir levels over time. And here's how this looked. So about 4,500 people were randomized, and just with the intention to treat cohort, you end up with about 280 in each for TDF-FTC, and then CAB, a couple of infections at enrollment. And just, if you can look at the retention over time, very good retention in this study. I'm always blown away by these. But, 75% at 24 months. And then for the primary efficacy cohort, there were about a little over 2,200 in each arm. So I wanted us to take a look at the study population, very balanced across both arms. I think, again, one of the key things to look at is first the goal of over 10% transgender women. They exceeded that, 12.5%. And then this was the very exciting thing that just under 70% were 18 to 29. And then you can see there's a nice, there's a good smattering from different countries. And then just in terms of looking at race and ethnicity, they met their standard of 50% Black or African American in the United States. And then you can see where see the other countries or the other continents that were involved. I did just knowing what our population is here in San Diego, the ethnicity for in the United States, Latinx, 18%, which is much lower than what we would normally see here. So not completely, a lot of this is not totally applicable to San Diego, but that is definitely an area where we exceed in terms of where our enrollments can go. So this is the big important slide, or one of the big important slides. They found 52 infections in 6,400 person years of follow-up, which was about 1.4 years per participant, with a pooled incidence of 0.81 per 100 person years, of which 13 were in the cabotegravir arm, 39 were in the TDF-FTC arm. And looking at the non-inferiority and superiority margins, it actually fell into the superior range, leading to the conclusion that cabotegravir was superior to oral TDF-FTC in this setting. And this is, I hope you can see this. I'll try to bring your eye to a couple of important things. So first is sort of the standard Kaplan-Meier curve. And I think, this is a beautiful slide. I keep thinking of Susan Little talking about some of the early COVID studies or the early vaccine studies results, and sort of what a researcher wants to achieve. And this is very much what you're hoping to see in studies like this, if you're rooting for one over the other. And you can see that, cabotegravir was just, there was much lower incidence in the cabotegravir arm. And then they looked at incident HIV infection in pre-specified subgroups. And again, I just want to bring your attention to a couple. So cabotegravir seemed to favor people under 30, MSM, individuals who identified as Black, and then people, individuals enrolled from the United States. Sorry, I'm just moving this so that I can, okay. And this is where there was a lot of talk about this, because this is sort of breaking down the pharmacologic and virologic data for the HIV infections in the cabotegravir group. There was a lot of talk about this, and there was a great talk about it at CROI that really went into it. And I'm not going to go into it in that much depth. Just so that you know, group A are for individuals who are infected before enrollment. Group B, and this is a group that I wanted us to look at, this is a group where the infection occurred with no recent exposure to cabotegravir. And I just want everyone to remember there was a lot of discussion about what might happen in individuals like this who became infected later, in terms of the tail and developing resistance mutations to NCs. That did not occur in these 4 individuals, which is very reassuring. And I'm not saying that the tail issue is put to rest, but this is definitely reassuring. Group C are infections that occurred before they got their injection, so during the oral lead-in. And then this is the group of sort of highest concern, and these are infections that occurred in participants with appropriately timed cabotegravir doses who also had expected plasma cabotegravir concentrations. And I'll talk about this a little bit more, but this is sort of the, I guess the bad news for the study, which is still obviously very, very good news, all told. Just wanted to go through the grade 2 adverse events and point out just some some statistically significant differences. No surprising creatinine clearance decreased in the TDF-FTC arm compared to the CAB arm. There is this finding of nasopharyngitis, which is slightly higher in cabotegravir arm, blood glucose elevated in cabotegravir, and then pyrexia in the cabotegravir arm as well, mostly related to the actual injection. So some important observations and conclusions, and I'll obviously, so I'll get to the observations first. There were 4 incident infections in the CAB arm, despite the target plasma CAB concentrations being reached. And they're working on understanding correlates of protection. The cabotegravir long-acting injection can delay the detection of infection using standard HIV testing algorithms, which I did not get into here. That would be a much longer talk. And that integrase resistance is seen when viremic escape occurs at higher CAB concentrations. But integrase resistance was not seen in the 3-tail phase infections or the 1-tail escape case. And I think this is the really key part is in the, and I didn't go through this data, that in the TDF-FTC arm, 37 out of 39 infections had suboptimal or non-adherence, which we know is one of the big issues with oral medications. So this is sort of a little bit of a change and a shift in the way we're thinking that viral load testing as a primary screen may be important and is going to be assessed in the 083 open label study. And in the setting of using cabotegravir long-acting, that prompt diagnosis and ART initiation are needed to avoid resistance. But the broad conclusion is that in 083, both were highly effective for HIV prevention, both CAB long-acting and TDF-FTC, but CAB-LA was superior to daily TDF-FTC, likely related primarily to adherence.
Jill, I have a question. Do you think with those 3 or 4 infections that occurred during the oral CAB phase that the guidance will be to shorten the oral phase, like to a week or something, to try and minimize that? Or do you think they're going to have to go with what was in the study?
So that's why they're going to be looking at, sorry, I actually removed it. In 083 open label, they're going to look at not having an oral lead-in at all. It's hard to know what the guidance will look like, but I'm guessing it may be shortened because tolerability does not seem to be, a huge issue, and that's really the main reason for that. But this will cabotegravir. I mean, I don't think this is a spoiler alert. I think it will be. I think it will be approved, and I think we'll be seeing it as long-acting HIV prevention come January, February. And so we won't know that answer from the study before then. So it will be interesting to see how they do it. And I'm guessing you might be right that they might shorten it. Dan.
Jill, quick question. So you had mentioned that Blacks seem to do better with the cabotegravir regimen. Do you think that that is just related to the entry criteria of having more Blacks at least enrolled in the study, or do you think there's something actually there, or can you comment?
Well, and I'm not a study investigator, so I haven't been part of these conversations. But if I had to say anything, I would imagine some of this has to do with sort of people not wanting, certain groups definitely being targeted, that TDF-FTC is not a good drug and has a lot of side effects and a lot of long-term adverse events. And I really think that this was a new regimen that, took that off the table. I mean, I think in general, we know that adherence is difficult for young people. And then there's certain groups where that may be even more difficult. So to me, I don't think it has to do with over enrollment or higher enrollment of Black individuals. I think this may have to do, for me, this had more to do with the fact that a lot of people don't want to take TDF-FTC for many reasons. And so the comparator came out better. That's just my guess. I'd be curious if others have thoughts.
Yeah, and I see here Darcy said maybe better adherence with the long-acting injection versus the PO related to stigma in this group. And Connie says she agrees with Darcy. It's more of a socio-demographic issue rather than a biologic issue.
Yeah, absolutely.
Great.
So, this is, really exciting data. And then I want to show really even more exciting data, or similarly exciting data, which has not yet been published, but has been presented multiple times. So this is the companion study, HPTN 084, which is long-acting injectable cabotegravir. Also is safe and effective in preventing HIV infection in cisgender women. And this study, so the planned enrollment was 3,200 people in 20 sites across 7 countries in sub-Saharan Africa. And the goal was, or the idea was to enroll cisgender women ages 18 to 45 or HIV negative and sexually active. They used a modified voice risk score, which came out of the voice trials and has been used in many subsequent studies, primarily in sub-Saharan Africa, to indicate risk. But they increased the cut point from 3 to 5 later in the study, or in their second iteration of the protocol. Couldn't have any contraindications. You couldn't be pregnant or breastfeeding, and you had to be using a reliable form of modern contraception. And from this date only, you could only use a LARC. So study design, oh gosh, sorry, my lights keep going off in here. I'm gonna try to move things around. I don't know how to do it. It's now very dark in my room. Give me 1 second. I don't know why this keeps going on. There we go. Kind of strange. I don't know if anyone else is having that issue in the AVRC. So similarly, 5 weeks of the oral lead-in, and then every 2 weeks, either cabotegravir, the active cab, or placebo cab, along with a daily pill. And then the third step was the open label, where they were just getting oral medication. So just shy of 5,000 were screened. They randomized over 3,200. You can see the allocation is very similar. Even better follow-up in this study, similar to other HIV prevention trials in Africa and cisgender women. And they analyzed about 1,600, they analyzed who were randomized and allocated to each arm for a total of just shy of 2,000 person years. So some of the participant baseline characteristics, I think one of the big things is, who's under the younger individuals, so less than 25. If people recall from other HIV prevention trials, there was often more difficulty or higher likelihood of seroconversion in younger age groups. So this was a key enrollment group for them. And then you can see the median voice risk score, which was quite high. Some of the STD data at baseline. And then the BMI, which I'm really not going to focus on that much here, but important and relevant to the TDF-FTC part of this. So the primary outcome for HIV incidence, there were 40 infections over about 4,000 person years, with a pooled HIV incidence of 1. And then this is the, really big, these are the big numbers. And I think this is, incredible. There were 4 infections in the CAB arm, 36 in the TDF-FTC arm. Similarly, and this is now really Dr. Little in my head, you can see just pretty much a flat line for cabotegravir. And this comes out to 89% lower risk of HIV infection compared to the TDF-FTC group in the CAB group. And this was thought to be, and I'm not showing this data, they looked at, plasma concentrations, TDF-FTC, and adherence was not good over time. And so the conclusion that it was that this was most likely due to the adherence advantage of the every 8-week injection. And then, sorry if this is a little bit of a noisy slide, but just again, the grade 2 events, relatively well distributed. And actually the creatinine clearance being decreased was about the same in each arm. And yeah, actually everything was relatively well distributed here. So slightly different than in the 083 study. There were 3 deaths in the cabotegravir arm. They were all ruled to be unrelated to the study product, which was very unfortunate. And then pregnancy outcomes, I just wanted to show them really no difference in either arm. There were the 4 pregnancy losses before 20 weeks. 3 of them were elective terminations. There were no congenital anomalies observed in either the live births or the pregnancy losses greater than 20 weeks. Yes, Darcy, I agree. You don't need statistics. That's when you can take the statistician away. Although some people are still not convinced by those Kaplan-Meier curves. So basically what they found were both agents were highly effective in preventing HIV, with a very a low pooled incidence of 1. But cabotegravir was superior to oral TDF, FTC for cisgender women with an 89% lower risk of HIV infection, and likely related to an adherence advantage over the daily oral TDF. And they are working on to figure out the reasons for the breakthrough infections in both arms. Both products were safe, well tolerated. There were few grade 2 or more adverse events except for injection site reaction, and that is definitely a real thing, although they're mild, associated with pain and occurred usually at the first injection, but notably there were no discontinuations due to ISR. And these results complement HPTN 083, confirm CAB as first safe and effective injectable PrEP agent for cisgender women. And I think this was, just such a huge study after, everything that has happened or that we've seen in studies in cisgender women. This was really the biggest bang, I'm just in awe of this data, really excited about it, and can't wait to see it also make its move to places like the United States and others. I will pause for a second. Yes.
Perfect. So I did get a question from Darcy asking about why does long-acting CAB lead to a delayed detection of HIV? Was it the way the study was done, or is there something about having received long-acting CAB?
So I think they're still trying to sort this out, but there is some thought that it might be related to receiving long-acting cabotegravir. Its potency and its effect can actually delay it on our our standard, 4th generation tests. And so, yeah, that's basically what that is. And this is really the first time I've seen, very serious discussion of requiring, viral loads as we go through, or as you screen people, or as you give people the injections. So yes, there does seem to be something related to the cabotegravir.
All right, I think that was the only question.
Okay, so now I'm going to move into Lena Capovir. Hopefully for the rest of the time, we'll talk about this. So Lena Capovir is a very exciting compound. It is it basically works at multiple capsid dependent sites or steps in HIV replication, which is unique so that it works both pre and post integration. And it has very high potency of 50 to 100 picomoles, depending on the cell type. And just to compare it to other NNRTIs, it's about 10 times more potent than rilpivirine and efavirenz. And then to compare to other integrase inhibitors, it's 20 times more potent than bictegravir and cabotegravir. It was developed to be a long-acting medication, and based on its properties of high potency, its pharmacokinetics, and its physical properties, that it's a low-soluble agent, it allows it to be injected every subcutaneous injections every 6 months. This is data from the phase 1 program that showed that plasma levels remain above target concentrations for about 6 months. And it takes a few weeks to reach target levels, so the oral loading is required in the absence of anything else. But the question is how long, how long do you need to do it? Again, in sorry, I was looking at Connie's comment as well. So the 5 weeks is what they did in the study, but is that going to end up being too long? Okay, so capsid inhibitors for HIV prevention. They basically have been able to use lenacapavir it's been established that it works in animal studies using rhesus macaques and both Shiv rectal and vaginal challenge models. And basically in these studies, they used the GSCA1, which is a close analog of lenacapavir. And rhesus macaques were given a series of either intrarectal or intravaginal challenges. And what you're able to see is obviously with the placebo, infection occurs or viremia occurs relatively quickly. But after many weeks, the levels, you don't see any infection. And for the vaginal ones, no infections occur long into different study weeks. So this is some of the proof of concept studies for this. And so lenacapavir, and this was talked about, I believe, by Miley briefly. Capella, we've talked about a little bit, and I just wanted to talk about the week 26 results, which were used for HIV treatment in patients living with HIV with multi-drug resistant HIV. And for this study, they got 14 days of either len oral or the placebo, and day 15 was the primary endpoint of this study, where and here in this study, 88% of participants had a greater than 0.5 log reduction in viral load compared to 17% in the placebo arm. And then individuals were moved to the lead subcutaneous every 6 months with the optimized background regimen. And at week 26, which is what this data is from, you can see that 89% in this arm had viral load less than 200. I'm actually just trying to see what this. Yeah, sorry. So this is the len arm, and this is the these were 2 different doses that was going on, 2 different doses, and the higher dose is where, I apologize, the higher dose was where they saw more success. And it did just want to, so actually, and as a result of these data, at the end of June, Gilead submitted the new drug application for Lena Capovir for people living with HIV with limited treatment options. And just a small plug, and I think Dr. Little will talk about this study at some point. She is going to be leading a study using Lena Capovir at different doses combined with monoclonal antibodies for treatment experienced individuals. Lena Capovir is also now being studied in treatment naive individuals. I just didn't present that, but that's the Calibrate study. It's still pretty early, and I'm sure there'll be some discussion around that in the future. So Lena Capovir for PrEP, this is what I wanted to spend a lot of time on too. So there are 2 big studies, the Purpose 1 and Purpose 2 studies that have been launched. And Purpose 1 is taking place solely in South Africa and Uganda, with the goal to enroll around 5,000 young women ages 16 to 25. And the study will be every 6-month subcutaneous Lena Capovir injection. What I'm going to speak about a little bit more is Purpose 2, which will evaluate safety and efficacy in just about 3,000 cisgender men who have sex with men, transgender women, transgender men, and gender non-binary individuals who have partners who are assigned male at birth. And Purpose 2 will actually, I'll show that in a little bit where it will be taking place. And I am very fortunate to be our site investigator here. So this is also a little bit of a discussion for recruitment, and so that people are aware of this very exciting study opportunity for these individuals. So the study design, it begins with a cross-sectional HIV incidence cohort to estimate the background HIV incidence. And there are 2 study arms, and I'm going to talk about this last, background HIV counterfactual, which will be the external control. And this is interesting, and I think it's a sort of a new way of thinking about how we can have a control group in studies who aren't on, active drug, because at this point we can't put people on placebo since we have so many agents that do work. For every 2-to-1, for every two people will be enrolled into the Len arm, and they'll get an FTDF oral placebo, and then for every 2, there will be 1 in the FTDF oral arm with Len placebo, which will go on for 52 weeks with a primary endpoint of looking at Lena Capovir compared to this background HIV counterfactual. And I'll explain that a little bit more in a second. Here's what it looks like, because there's also a part B. And excuse me. So as I talked about, this is the 52 weeks. And there is then an open label phase, should everything look good in the blinded phase, because there will be a review. There will be reviews throughout the part A by DSMB. And then, as in all these other studies, there'll be a PK tail coverage while subsequently taking FTDF orally. And again, the major point here is that HIV incidence in the trial arms will be compared to the background HIV incidence rate. So how do we get that? And that's using this counterfactual HIV incidence design. I wanted to show that we've been using counterfactuals for years. And it's been used for many years in studies of new contraceptives, because again, like PrEP, you couldn't just put someone in a placebo arm. There will be, a very low expected rate of endpoints, which would be pregnancies if you compare to someone, to a group that's taking contraceptions. So a non-inferiority design is really difficult. So what you do is you compare the pregnancy rate for participants taking the investigational compared to the expected counterfactual pregnancy rate for those who had not been taking contraception. So we can apply that, and that's what we're doing here. We would apply the same study design for people taking HIV prevention medications, which is to basically look at those who are being screened for study and calculate that incidence along the way. And that's what I showed, that we'll be looking at the background HIV counterfactual throughout it, with people being looking to come into this study, and we'll calculate this HIV incidence cohort along the way. Now, in order to actually make this work, though, people have to be at risk if you're going to actually calculate, HIV infections. So one of the big things about this study that's been certainly, I get somewhat controversial, is that you can't have had an HIV test in the last 3 months. They're not excluding people who are already on PrEP, but for those of us who prescribe PrEP, know that people who are taking it can do very well with it. And these are likely people to not be infected with HIV when they go to enroll. So I suspect at some point during this study, they may remove that, and it has to be PrEP naive individuals. But that's basically how that works. You do need to have people who haven't recently tested for HIV. So how are we going to do the counterfactual HIV incidence? There are lots of ways to do it. But one of the most common ways of doing this is using the recent infection testing algorithm. Sorry, my lights went off again. And so these tests basically can identify whether a person with HIV has acquired the HIV recently or remotely. It's based on the temporal dynamics of the HIV antibody. When people acquire HIV infection, the binding strength or the avidity of their HIV antibodies is low. Oops, sorry. And over time, the immune system adapts, and then you get higher avidity antibodies. So basically, the higher you can then make a correlation between antibody avidity and the duration of HIV infection. And this is what's been used in the PERC cohort for years. And they use a modified EIA to do this, and then they'll therefore be able to measure recent infection. Just wanted to show you lots of USA study sites. We are very excited to be the San Diego site, but there are sites in lots of places, and they really, the study investigators really did a good job of getting into different places and bringing new investigators and new sites to the table that haven't traditionally been part of HIV prevention sites. In all, there's 77 US sites, 8 Brazil sites, 4 Peru sites, and 4 South African sites. And just a couple of things that make this study, I think, really exciting is the very big focus on Black, gay, bi, and other MSM in Purpose 2, as was done in 083. And, this is not news to anyone here. We all know that the lifetime risk for Black MSM is 1 in 2 compared to 1 in 11. For white MSM, PrEP uptake is lower in Black MSM compared to other groups. And we know that they've been underrepresented in clinical trials. The HPTN came out in 2014 recommending that all protocols involving MSM should try to include recruitment goals of 50% Black MSM. And what Purpose 2 has done is establish both study-wide and very site-specific goals related to what the local environment looks like to ensure adequate inclusion of Black MSM. In addition, there is a strong, effort to include transgender and gender non-binary people. I showed you in 083 that the goal was over 10%. The goal in this study is about 20%. We know that HIV prevalence worldwide is around 20% with different rates in various countries. And they've also been underrepresented in HIV research. And then the other thing that is somewhat unique to the study, although we were here in CCTG 603, and there were other studies involving transgender individuals in California, where people of all gender identities were invited to participate in the study. But this in particular, there's a focus on transmasculine people, to include transmasculine individuals. And this is a great quote from someone in a really cool manifesto called No Data, No More, which is for a manifesto of priorities of trans and gender diverse people. As a transmasculine person who has sex with cis men, my identity is historically and consistently overlooked. So this is another group that is going to be included in this. And I will show you where that there may be a slight limitation there, but this data or this approach was actually written up for an IDSA abstract, and it basically just describes, sorry that this is a little bit noisy here, but just doing a multifactorial approach to address historic underrepresentation, which included a large literature review of successful evidence-based approaches to enrolling certain, these underrepresented individuals, and then heavily engaging with community and patient advocates and key stakeholders before the protocol was developed, as opposed to what often happens, which is protocol is developed and then it's shown to people. There was a trial-specific global CAB that was created, which helped guide site selection, investigator and staff diversity, and creation of strong linkages with CBOs. Like I said, new community-based research site and PIs to help mirror the groups that were that are part of this study, and a huge emphasis on young sub-investigators. And there have been trainings for all study and site staff on good participatory practices for PrEP, anti-racism, and transgender cultural humility. We talked about the goals that were established, and that this is, this was a novel approach to increase diversity, equity, and inclusion, which we hope can be replicated in other studies going forward. So these are our study recruitment flyers. And what I want to bring up is the eligibility criteria. And there's some more in depth, but I think one of the big parts is that you do need to be, the patient or the participant needs to be having receptive anal sex, which is a little bit of a difference than studies that we've talked about in the past. And this was definitely a hard sticking point. It was sort of debated, it sounds like, among lots of groups. And again, I mentioned that you haven't been tested for HIV in the past 3 months. Right now, individuals can be on PrEP, but again, the HIV test has to be no sooner than 3 months, and that may change. George Lara Paez is our wonderful study coordinator. We have not started enrollment yet. They have now, they've enrolled, I think about 50 individuals with 20 to 30, somewhere in that range, randomized. Our site has not started up yet. They're doing sort of a slow rollout, partly related to COVID and staffing capabilities. So what I was hoping to have a discussion about were, and I'd love to hear from other people, and we can talk about it more at the end, but some of the pitfalls for long-acting injectables for PrEP and what we have to keep an eye out for and why we can't get maybe too excited. I think one of the issues that really was a major concern was this development of drug resistance related to the PK tail. But I think what's been, it's exciting and it's new. It was only, some thousands of individuals. It wasn't found in 083 or 084. Obviously, I think time will tell. I think it's possible we will see that, just as we have in the real world for TDF and FTC, more emergence of M184 resistance mutations. So, but at least the study was reassuring. At least for long-acting injectable cabotegravir, clinic visits or pharmacy visits are every 2 months, which may not match up with the CDC testing guidelines, which are every 3 months, which could be a little bit awkward. And you'd have to figure out, how to get patients in without overwhelming them. And especially if the idea is that viral load testing is going to be needed, it may be difficult to do at-home testing, although I know there's always exciting new stuff coming out that could change that. But obviously for Lena Capovir every 6 months, that would be less of an issue. And then just the dreaded insurance coverage and clinic pharmacy logistics. I think this is being seen for Cabenuva. And, who will be covered? Will it be added, at least in California, to the PrEP assistance program guide formulary? So will it even be available? And all these things are yet to be seen and will unfold as things come out. And I think, Darcy brought this up last week, and I think is, a concern sort of connected to what I was saying with insurance coverage and clinic pharmacy logistics. We already know that there are disparities in who uptakes PrEP. And we saw in 083 that, Black individuals actually seem to do better. But could the challenges with access or disparities in access actually end up leading to greater disparities and widening this gap? And maybe I'll pause for a second because I'm curious what other people think.
All right, so if anyone has any comments, you can go ahead and unmute yourself or raise your hand.
All right, we can do it in a little bit. I mean, that was very comprehensive.
Darcy, I think,
was
has
just going to
comment.
say, I think it really comes down to insurance coverage as a piece of it, at least, because if this isn't covered, which hopefully it will be, it won't be an issue, but if it is, then you could see people with less good insurance coverage sort of driving the disparities. And then I think a big piece of it will be kind of marketing, education, advertising to groups at high risk and that have traditionally not done as well with PrEP or access PrEP in order to get it to people who really need it. And I think, it's really, I think that's a testament to the way that these studies were designed, right? And that they really tried to enroll people where we're seeing all of the disparities to really have the data to support that this can be something that's really helpful. So those are just my random thoughts.
Thanks, Darcy.
So
Connie's hand is up.
Connie?
Yeah, I was just going to say something similar to what Darcy was saying, but I also wanted to ask about what people think about the clinic and pharmacy logistics. What I've heard from other people is that it's difficult to organize a PrEP clinic around long-acting injectables and getting people back on time for their next injection, or how, if they don't show up for their next injection, what's the coverage in terms of giving them a prescription for oral therapy during a period of time when they can't make it back for injections. I think there's a lot of logistical issues, and I wonder how you might be planning for this or thinking about it at the Owen Clinic.
I think that was such a great question, because the person who is raising their hand next is Dr. Hill. So Lucas, Would you like to comment on this?
Sure. Yeah. And then I had a question for you, Jill. But yeah, I think we can obviously learn from our Cabenuva experience and kind of what we're doing with that. And it is very labor intensive, both to get access to the drug, but then to do all the tracking to make sure that patients are getting in for their injections and not missing, and then, doing outreach when they do. So I think probably the biggest takeaway is the comment from last week's presentation, which was you can't have a PrEP clinic without a PrEP navigator. And so, I think that there's going to have to be dedicated resources to doing all of this work. So, I think we're already talking about it for Cabenuva at Owen, is that, we're having our pharmacy team do it, but we really need to hire someone specifically focused, probably like a pharmacy technician on long-acting injectable therapies to do outreach and insurance and all that stuff. And I think the same thing's going to apply for CAB for PrEP too. So yeah. And then Jill, I just had a question about what you think about, so I think about our retention, right, in our PrEP clinic and our patients who are young and generally healthy and not too well versed within the healthcare system. And I think it's easy to tell patients, if you don't take your pill, you're not protected. But it's a little bit more difficult when you're doing an injection every 2 months, I think, maybe for patients to understand when they are or are not at risk, especially if they're late and they don't come in or they forget. How do you think this is going to work for like our younger patients who are already struggling to be retained? And now they don't have a daily pill to remind them that they are or not protected from HIV.
Lucas, I think that's a great question. And I do think it's going to take, as you said, probably some additional work and greater discussions with them. I will, though, point to the 083 data, which showed that, for people under 30, this was actually a better strategy than, FTDF. And I think what we've learned with young people is that daily pill taking is really difficult. And I'm going to come to Jeff in a second, but I do have the flip side of the pitfalls, which is the promise. And I want to make sure we end on a positive note, because I think this is really just so exciting. But I think the daily pill is really hard for a lot of people, and having this other option, and I think, I believe that this isn't meant to be for everyone. It's not like we're going to take everyone and move them to long-acting injectables. This is just another option for people to have. And we'll have to figure out who those best people are as we go, I think. Jeff, I'm trying to be mindful of the time as it's almost 9.
Yeah, no, just quickly, I just wanted to pile on to the other comments about the logistics of doing this in the clinic. And what I'm hearing anecdotally here in Palm Springs and in several of the clinics is that they just don't have the staff to do it. And some are actually opting out, even though they have well-insured patients. It's just the logistics of making it happen. And I think once they have new formulations of this or other long-acting drugs that are, 3 months or 6 months, that'll really simplify things, especially 6 months. Right,
I think that's a great point, that when we have more of these, there'll be more of a need to hire for this. But right now, yeah, I feel bad for Cabenuva kind of eking itself out without the support it needs. Go ahead, Shannon.
Great job, Jill. And thanks for all the great discussion, everybody. The only thing I think about, just to comment about, just brainstorming in terms of Lucas's question about how do we motivate people to stay engaged and retain them in these clinics. And I think just always looking for kind of the motivator, the driver, thinking about people that are on long-acting contraception, for example, what's the perceived risk and what's kind of motivating them to come back for that. And I think that might have also been a barrier for oral therapy, because if you're not actually sick, you may have a different level, each individual, motivating the individual to really identify what's going to motivate them to come back, and educating them about their level of risk, I think will be really, really helpful to get them to actually come back in, for sure.
Thanks, Shannon. I think this is a good segue into this last slide, if I can go through it. I see that Lucas's hand is up again, and I'll let you jump in. Obviously, I realize it's 9 o'clock, so whoever needs to go, please do. So I think what's just so exciting about this, as I said, no more daily pills. That was, that's a big issue for a lot of people. And I think what that can mean is increased self-efficacy and agency, where you don't have to rely on something every day. It sounds like, it seems like improved adherence for many people. I think this big issue of decreased stigma where you don't have to take the pill every day. And maybe there are fewer barriers to care, although we've obviously talked about some of the barriers that may arise. The choice is good. I think that was from the Taco Bell commercial. We know that HIV prevention is not a one-size-fits-all model, and having more of these options will be beneficial to all. Some of the side effects that perhaps we see with FTDF and FTAF, maybe they won't be, maybe we'll have fewer side effects potentially with a different agent. And then I think just the bigger point of this is, does this get us closer to the goal of ending the HIV epidemic, which is sort of the big point of all of this. I just want to thank a few people who provided slides and feedback, and George, Steve, and Helen for helping move forward Purpose 2 here, which is always sort of a big ask. And I was going to leave it on this because a lot of people have been asking. Here are some pictures from my wedding, which was my big fun fact for people. I got married a couple of weeks ago, and here are some pictures. But if Lucas is still on and you want to ask your question, I think you had your hand up.
He didn't have any other questions, so
okay.
no worries. So, well, thank you, Jill, for an excellent talk and good discussion. So everyone have a great weekend. Thank you for attending, and hopefully we'll see you next week. Thank you.
Thanks, everybody.